Okay, so in this lecture, we're going to talk about some of the therapeutic approaches to asthma. Just as a brief reminder, this is an introduction, of course. This is one of the earlier cases, and so we're going to just kind of introduce some of the major drugs that are used for the acute treatment of asthma. And then as we revisit this disease process, in a much later case, we'll finish all the other drugs that are used to treat this condition. And one thing to keep in mind, many of the drugs that are discussed here represent a new form of delivery, and that being inhalers, which have essentially unique pharmacokinetic properties. And so the second half of this lecture will kind of focus on some of the unique pharmacokinetics of inhalation therapy. Learning objectives are described here. We're really only going to talk about three drug classes: the beta-2 agonist, the antimuscarinic antagonists, M3 muscarinic antagonists, and corticosteroids. And we'll also talk about some of the major side effects associated with these drugs and some of their unique pharmacokinetic nuances and unique pharmacokinetic properties that's associated with these drugs. Okay, so you can kind of break this lecture into two parts. Drugs that are going to target inflammation, and those are basically corticosteroids, and they can be further subdivided into orally administered corticosteroids, really just prednisone and methylprednisone, and then the inhaled corticosteroids, which are listed here. Then the other group of drugs I would classify as something like mechanical. And so these are two drug classes that essentially work on bronchial smooth muscle. And we'll talk about their mechanisms of action. And so these are the beta-2 agonists and the anticholinergics, or the antimuscarinics. It's one and the same. They've got two different descriptors in terms of how these drugs are named. So just to summarize, the beta-2 agonist mechanistically essentially relax the smooth muscle that surrounds the bronchi. And they're also responsible for kind of releasing some of these bronchoconstricting mediators that are coming from mast cells. Also, you'll see a reduction in microvascular leakage, and you'll see mechanistically the stimulation of adenyl cyclase and increased concentrations of cyclic AMP. We'll talk about this mechanism in much more detail in the upcoming lectures, but essentially what happens is that there's a maximal bronchodilation that occurs within about 10 or 15 minutes and persists for anywhere from 3 to 4 hours for the short-acting beta agonists. SABAs are short-acting beta agonists, or 10 to 12 hours, and those are the long-acting beta agonists. And so mechanistically they work the same. The only difference really between these two drug classes is how long they work for. And so of course these are inhaled drugs. The short-acting beta agonists offer relatively quick relief of asthma. And those drugs include albuterol, also known as salbutamol, levobuterol, and some of these other ones that are listed here. Albuterol is probably the most commonly encountered one. Albuterol and terbutaline have also been formulated for tablet form, and terbutaline specifically has also been formulated for subdermal injection. All right, so the long-acting beta agonists offer control for asthma for up to 12 hours. And these are not to really be used as monotherapy for kind of a long-term control of asthma. And you typically see them in combinations with ICS, or inhaled corticosteroids. And so, mechanistically together, these two drugs in combination work really well. And for children especially, the patient population that includes children, there is really good evidence that these are actually kind of the preferred therapeutic approaches. And so we'll, again, talk about that. And so the prototype here, the long-acting beta-2 agonist, includes salmeterol. And there's a distinction that salmeterol is a partial agonist. We'll get into that, but essentially all these drugs have a very similar mechanism of action, and that is basically stimulating or agonizing the beta-2 receptor. Okay, and so those are the beta-2 receptor agonists. And the other group of drugs that work pretty similarly are the anticholinergics. And so these are M3 receptor antagonists. And so these are going to inhibit the muscarinic cholinergic receptors, and they work similar to atropine. They're going to reduce intrinsic vagal tone within the area, and that's going to kind of be counter to the acetylcholine effects. A lot of these patients have relatively strong autonomic control, and that kind of promotes some of the bronchoconstriction. Some patients have much less. But in any case, these drugs block the M3 receptor, and they promote smooth muscle relaxation, much like the beta-2 agonist through a different mechanism. There's only two drugs that are anticholinergics that are used clinically: ipratropium bromide and tiotropium, or tiotropium, however you want to say it. Tiotropium is much longer acting, and the nuances between ipratropium are listed there. It's inhaled quaternary amine. It has relatively poor oral absorption, so it must be inhaled through some type of inhaler or nebulizer, and it has relatively no CNS effects. So when we learn about the muscarinic receptors, that's important because several muscarinic receptors are located within the CNS compartment. Ipratropium and tiotropium have no CNS effects, and so they're very specific for the muscarinic receptors that are associated with the pathophysiology of asthma. Okay, and the other thing is that these may be alternative to patients who, for various reasons, did not tolerate or respond to the short-acting beta agonist, the SABAs, short-acting beta agonists. And so the mechanisms are relatively similar. So here's your M3 antagonist, and they basically inhibit smooth muscle contraction. Your beta-2 agonist basically promote smooth muscle relaxation. So inhibition of contraction and promotion of relaxation is essentially the same thing. You get bronchial relaxation and a nice opening of the bronchial airway compartment. Excuse me. And of course, both of these drug classes have side effects and toxicities associated with them, but they're relatively relatively low in terms of the number of side effects and the potency of these side effects. And so beta-2 agonists are usually associated with excitement and nervousness in some children. The tremor can be associated with the use of beta-2 agonists, and that usually increases with age. Of course, you're setting the patient up for increased incidence or occurrence of respiratory tract infections, including rhinitis. And of course, contraindications to beta-2 agonists include pregnancy and a history of hypersensitivity reactions to these drugs. Muscarinic antagonists include the bronchi or the sinuses being inflamed, persistent headache, dry mouth, cough, runny nose, and of course contraindications would be basically a history of sensitivity to atropine-like compounds. And so we haven't talked about what atropine is, but it is an anticholinergic type drug, and it shares some structural similarity to ipratropium, but more selectivity in terms of what it binds to. So these are basically the kind of the mainstay therapeutic approaches to asthma therapy, and the whole physical concept here is going to be to really kind of reduce the bronchial tone and promote bronchial relaxation to assist with basically, enhanced airway flow. The next group of drugs are going to be corticosteroids, and we'll end here and we'll pick up on corticosteroids in the next mini lecture.